Thank you for joining the 12th Annual PIPC Forum. It's hard to believe that it's been 12 years. I'm grateful to see our progress advancing the voices of patients and people with disabilities in research and healthcare decision-making. We have come a long way, but we have much more to do. The United States Congress passed the Americans with Disabilities Act over 30 years ago because of one thing: disability is not unique to any political party or demographic. My friend Bob Dole, a disabled World War II veteran, recently passed away and reminded me yet again the importance of this fact. Bob said, "Having a disability changes your whole life, not just your attitude." When I think about some of our greatest achievements in the disability community, they are often the result of what unites us. A quarter of the population is disabled, and half the population is connected to disability somehow. That means many people understand the value of accommodations and the need for policies against discrimination. Because of great people like Bob Dole, the ADA had bipartisan support. Later, the Patient-Centered Outcomes Research Institute, or PICORI, was created because members on both sides of the aisle came together to draft the original bill that was eventually included in the Affordable Care Act. Today, we hear from the chairman of the National Council on Disability, an important federal agency, about its work to advance the promise of the ADA. I can say without a doubt that their work has been tremendously influential in everything that we do at PIPC. When we were working with Congress to pass the legislation creating PICORI, we thought that the bar on using quality adjusted life year by Medicare was enough. However, the National Council on Disabilities report in 2019 told us we still had work to do. The use of QALYs rising and not falling means that we were seeing discrimination in healthcare rising, not falling. Discrimination is not always out in the open. When decisions are made about people's access to care based on averages, those of us who are not average are disadvantaged. Treatment may be more beneficial and critical to us than average patient. That is why we wanted so badly for PICORI to be created and to focus its work on how treatments impact different people. We wanted information on what works, for whom, and why. We not only need to fight for more information that helps us personalize our care, we must fight against policymakers and payers using information about the averages to limit or restrict what we care and can get. Having epilepsy myself, I understand this all too well, since I must change my medications when they stop working. We know from our own surveys of people that regardless of political party, people want to receive the health care that their providers determine will achieve their goals. They do not want cost effectiveness to drive decisions about our care. When that happens, we are telling people living with disabilities and chronic conditions, people with expensive care needs, that we aren't worth it. In my view, this is a violation of the ADA and Section 504 of the Rehabilitation Act. I'm willing to fight to do everything I can to support the National Council on Disabilities efforts to get a full ban on the use of discriminatory metrics like the quality adjusted life year in the Build Back Better bill, and to do what I can to support their recommendation that disability rights laws are enforced against the use of these discriminatory metrics in Medicare and in state Medicaid programs. I would add that people with disabilities need to be engaged partners in decisions made about the value of their health care. I'm grateful that Democrats and our Republican colleagues are with us in this fight. President Biden has stated his opposition to the quality adjusted life year. The DNC platform explicitly opposes its use. Senators of both parties have written letters acknowledging their historic discrimination using discriminatory metrics like quality adjusted life years. With such tremendous public and political support, I hope we can come together to advocate alongside the National Council on Disability to, as they say, unambiguously ban the use of discriminatory metrics in value assessment from being used in federal programs like Medicare and Medicaid. And I want to personally thank the chairman of the National Council on Disability, Andres Gallegos, for presenting to you, our audience, today about their work. If you've not read his piece from earlier this year in Health Affairs, I would urge you to do so. He captures the stigma that leads others to view us, disabled people, as having a low quality of life. And he outlines explicit steps to ensure that we do not devalue disabled lives in our policies. He's carrying on the fight for people with disabilities, and I could not be more grateful and proud of him. In closing, I appreciate all of you for being here and for listening. I hope you will join this fight with us. Thank you.
Greetings from the National Council on Disability, the federal government's independent, nonpartisan advisory body that informs the work of Congress and the administration. We speak on behalf of the interests and concerns of the over 61 million people with disabilities in the United States and in our territories. I am Andres Gallegos, NCD's current chairman. It is my distinct honor to join you to briefly explain NCD's latest engagement on this incredibly important topic, the dangers of the use of quality adjusted life years, or the QALY. NCD first engaged this topic of the QALY in 2019 as part of our bioethics series of reports. Admittedly, health economics can be an intimidating one to engage. If you're looking for a primer on the topic, I encourage you to read our report, as it is a good introduction to the issues. You can find it at ncd.gov. In that report, we sought to make the case that QALY perpetuates unequal access to medical care, including life-saving care. In our report, we document the inability of patients with disabilities to access life-sustaining, life-saving, and life-changing medications in countries where the QALY is used. When health insurance will not cover medically necessary medications and treatment, individuals experience poorer health and lower life expectancies. Said differently, the QALY perpetuates health inequities for people with disabilities. Not only does it have a discriminatory effect, the QALY discriminates in design as well. It is a pricing methodology that devalues the lives of people with disabilities. The calculation relied upon by the QALY reduces the value of treatments that do not bring a person back to perfect health, in a sense of not having a disability and meeting society's definitions of healthy and functioning. In that school of mathematics, you can imagine how disadvantaged scores of people with disabilities truly are. Shortly after I became chair of the National Council on Disability on the afternoon of President Biden's inauguration, I announced my vision for the council during my tenure as one that would stay focused on achieving health equity for people across all categories of disabilities. It's my sincere belief that health is the predicate for improvements in living, learning, and earning for people with disabilities. I began my tenure as chair approximately a year into this global pandemic, a pandemic that has unmasked the extent to which explicit and implicit bias against people with disabilities affects treatment decisions. We saw states like Alabama, Arizona, Kansas, Pennsylvania, Tennessee, and others establish crisis standards of care. Guidelines for the use of scarce medical equipment, medication, supplies, and personnel that would expressly base triage decisions on normative quality of life judgments, or that excluded from treatment patients requiring assistance with activities of daily living, or those with certain conditions such as severe or profound mental retardation, those are their words, moderate to severe dementia, and pre-existing conditions that are disabilities. Now I want to be clear. The NCD is in favor of supporting lower drug prices. People across America, including people with disabilities, need access to lower prescription medications. High drug prices themselves can be a significant, if not insurmountable, barrier to access quality health care. But we are not interested in giving policy advice that trades one barrier for another. However, the pursuit of lower drug prices should not be borne on the back of any group of people, and particularly not people with disabilities. We already have a formidable history of experiencing inequities in accessing health care. Misperceptions of people with disabilities on the part of medical providers already lead to low quality of care. There's a horrifying, extensive body of research proving this. In fact, in a recently published survey, it was revealed that 82% of physicians in this country believe that people with significant disabilities have a lower quality of life than non-disabled people. 82%. That's shocking but not surprising for those of us with lived experience accessing healthcare. Here's the shameful reality. Today in the United States, if you're a person with a physical, intellectual, or developmental disability, your life expectancy is less than that of someone without disabilities. As compared to our non-disabled counterparts, you are at a higher risk for early onset of cardiovascular disease. You are more than twice as likely to be obese. You are more than 3 times likely to have diabetes. You are significantly more likely to have unmet medical, dental, and prescription needs. These disparities are exacerbated if you are disabled and a woman, or disabled and a person of color. The existence and extent of these health disparities often have nothing to do with disabilities per se, and are often preventable, but they have everything to do with how physicians see us and how they treat us. Explicit and implicit discriminatory bias within healthcare professions represents an insidious virus against which people with disabilities have been fighting for decades. Where it is used, the QALY is an additional embedded bias, cloaked under the virtue of cost savings. Now, what may surprise some is that QALY is not a new idea in the United States, nor is the understanding of its discriminatory design and impact. When Oregon first attempted to use QALY in its state Medicaid plan in the 1990s, CMS rejected the plan, finding that it violated the Americans with Disabilities Act. And the history of restricted access to treatments occurring in countries utilizing the QALY raised concerns that its use here in the United States would result in rationed care. That led Congress in 2009 to prohibit or severely limit its use by certain federal agencies under the Affordable Care Act. The language in the Affordable Care Act stated that the Secretary of the United States Department of Health and Human Services shall not use evidence or findings from comparative clinical effectiveness research in determining coverage, reimbursement, or incentive programs in a manner that treats extending the life of an elderly, disabled, or terminally ill individual as of lower value than extending the life of an individual who is younger, non-disabled, or terminally ill. It instructed the Patient-Centered Outcomes Research Institute to not develop or employ a dollars per quality adjusted life year, or similar measure that discounts the value of a life because of an individual's disability, as a threshold to establish what type of healthcare is cost-effective or recommended. In our most recent advice to Congress, we advise that Congress extend those prohibitions throughout federal programs. The Build Back Better Act is a tremendous opportunity to do so and to memorialize the protections with an unambiguous ban of the use of QALY. We remain hopeful that our advice will be heeded as we all await the final text of that bill. I will close with my remarks here with a statement that summarizes NCD's advice to policymakers regarding the use of QALY. Decision-making tools designed around measures that devalue the lives of people with disabilities are discriminatory. They have no place in modern disability policy, particularly in light of our current administration, whose leadership has rightly emphasized the importance of achieving and advancing equity. I want to thank you for the opportunity to share my comments with you today.
Hello, and thank you for having me. I'm Caitlin McCormick, the Associate Director for Public Policy and Government Affairs here at PIPC. I wish I could be with you in person today, but I'm delighted to deliver this message to your forum. The relationship that PIPC and PIPC have enjoyed over the years is so important for the health research community overall. I thank you for your partnership and support all these years. I don't think I need to introduce any of you to PIPC, but I will mention that over our more than 10 years of funding research, we have now committed about $3.3 billion to more than 1,800 research, dissemination, implementation, and engagement projects focused on comparative clinical effectiveness research, infrastructure projects, including the Patient-Centered Outcomes Research Network, and projects focused on the methods used for our funded research. This year, we launched a strategic planning initiative that will determine the kinds of studies we fund in the future and will help us do our part in reshaping the U.S. healthcare system. And groups like PIPC are critical to us as we engage in this process. And throughout this time, we have sought and will continue to seek input from a wide variety of sources and stakeholders, including all of you. Today, we are focused on a critical process to moving PIPC forward, updating our national priorities for health and our research agenda. Over the past year or so, PIPC has developed our new national priorities for health, a set of high-level priorities that will drive our detailed research agenda for the next phase of PIPC's work. After a robust comment period, our board approved the following as our new national priorities for health: increase evidence for existing interventions and emerging innovation in health, enhance infrastructure to accelerate patient-centered outcomes research, advance the science of dissemination, implementation, and health communication, achieve health equity, and accelerate progress toward an integrated learning health system. This set of aspirational goals will update the national priorities for research that have guided our work this far. Moving from priorities for research to priorities for health is significant, and that the focus is now more on outcomes than on the process for achieving them. You'll note that all of these priorities begin with a strong action verb like advance, accelerate, and achieve. We believe these kinds of words will provide North Stars to guide us in making funding decisions that will provide evidence needed to achieve these goals. We anticipate that this shift towards achieving health goals will also entail partners beyond the formal healthcare system, such as in the fields of education, public health, and housing, all of which play a role in community and individual health. These national priorities will chart PIPC's course for the next phase of our work, and I think will provide many opportunities for further collaboration between our two organizations. With our national priorities for health in place, we have turned now to developing our research agenda. Our draft research agenda has been approved by our board and is now available for public comment. Our research agenda provides a framework for achieving progress on the national priorities for health, specifically through the strategy of funding comparative clinical effectiveness research. The research agenda will then help guide the development of an iterative research project agenda, which will be informed by an ongoing stakeholder-engaged input process. The research project agenda is where specific topics reside, such as intellectual and developmental disabilities and maternal morbidity and mortality, both of which were specifically identified in PIPC's reauthorization legislation. The proposed research agenda comprises 6 statements that all begin with fund research that, to emphasize the connection to funding CER. The 6 statements are: Fund research that fills patient and stakeholder prioritized evidence gaps and is representative of diverse patient populations and settings. Fund research that aims to achieve health equity and eliminate health and healthcare disparities. Fund research that builds the evidence base for emerging interventions by leveraging the full range of data resources and partnerships. Fund research that examines the diverse burdens and clinical and economic impacts important to patients and other stakeholders. Fund research that focuses on health promotion and illness prevention by addressing health drivers that occur where people live, work, learn, and play. Fund research that integrates implementation science and that advances approaches for communicating evidence so the public can access, understand, and act on research findings. This research agenda will be open for public comment through the end of January, and I urge you to submit your input for our consideration. Other things that we have been working on rolling out at PCORI include the provision of our reauthorization that authorized our full collection of the full range of outcomes data, meaning that future PCORI-funded research can now include consideration of economic impact of health interventions. This means not only traditional measures of utilization and costs, but also a specific focus on the non-medical costs to patients and families, such as caregiver burden, workplace productivity, and absenteeism. It's important to note that this language does not remove the statutory prohibitions on PCORI establishing cost per quality adjusted life year, QALY thresholds, or allow PCORI to conduct cost effectiveness analyses. PCORI has been working through an approach to this new provision that ensures transparency, notably patient engagement throughout implementation, considers the full range of treatment options, develops standards about identifying, capturing patient-centric cost data, addresses concerns around the use and misuse of cost data that could lead to cost effectiveness or inappropriate value assessment, and hopes to expand beyond traditional health economic perspectives on cost and value. To guide the use of this data, we have developed 4 principles. First, considering the full range of outcomes important to patients and caregivers, including burdens and economic impacts, is central to PCORI-funded research. Second, PCORI-funded research may consider the full range of outcomes relevant to other stakeholders when these outcomes have a near-term or longer-term impact on patients. Third, the collection of data on potential burdens and economic impacts of treatment options must be appropriate and relevant to the clinical aims of the study. And finally, fourth, PCORI may support the conduct of certain types of economic analyses as part of a funded research study or independently to enhance the relevance and value to patients and other stakeholders of information PCORI-funded investigators collect on potential burdens and economic impacts. To further support our research in appropriately collecting and using this data, we are establishing an economic resource center that will provide further technical advice and guidance. In addition, we will be funding a series of engagement awards that provide program support to further exploring the topic of economic impact data in research. In other new developments, we recently held a request for information on the science of engagement. In this RFI, PCORI sought input to inform the potential development of a science of engagement funding initiative. Science of engagement is the systematic study of methods for and outcomes of engagement to inform high-quality, patient-centered research. Expanded funding for science of engagement could address high-priority knowledge gaps on approaches for effectively engaging diverse stakeholders throughout the research process. The Science of Engagement initiative could potentially involve 2 complementary, interrelated research program approaches: standalone research awards on engagement in research and studies within a study for ongoing PCOR CER awards. The intention of these complementary mechanisms would be to help create a strong evidence base of answers to critical research gaps that could be addressed to make engagement more effective and widespread. And as always, we continue to focus on improving the science of engagement in many ways. We've also developed a series of learning resources found on our website that can be used by researchers to help them succeed in conducting research in multi-stakeholder teams. It addresses 2 key areas: engaging stakeholders to be active members of the team and working together as a productive team. We've also developed a Research Fundamentals program, which is a free comprehensive training package that offers different ways to learn about the health research process and be involved in patient-centered outcomes research. It's designed to help you understand the language and logic of the research process in an engaging and easy-to-grasp way. These new resources encapsulate what we have learned to date to support the practice of engagement. PCORI is always looking at how to fill gaps in evidence in the science of engagement to continue to support our awardees and stakeholder communities in PCOR. I'd like to thank you again for having me and reiterate PCORI's support for patient-centeredness in all research initiatives. We believe this is a core value of our health system and is at the heart of everything we do here at PCORI. I'll also leave you with a plea. Please submit your comments about our draft research agenda and spread the word far and wide with your colleagues and contacts. You can submit comments through our website either through formal written comments or through more informal methods, including leaving us a voice message. This is a really important way for the community to let PCORI know what they care about, so please spread the word about this opportunity. Thank you again, and I wish you all the best in the rest of your forum. Have a great day.